I'd like to thank you all for joining us this morning. My name is Karen Curtis, and I am a Provider Outreach and Education Specialist here at WPS Government Health Administrators. I'm joined today by my friend and coworker, Aline Sigler. Aline will be monitoring the chat for questions and may be providing you with additional information when needed. I would like to remind everyone that this course is for providers who bill Medicare using the UB04 form or the 837I electronic equivalent. As stated in the title, this is an introduction, so we will be going over some FISS basics. We have new providers that may not know a lot about the system, and with the closure of the claims correction line, providers are having to become more familiar with FISS, so I wanted to take this opportunity to provide some ground level information. This next slide is our disclaimer. We do our best to provide the most current, accurate information, but as we all know, Medicare rules change often. The information that I am presenting is accurate as of today, but the CMS website should be checked often for updates. CMS does prohibit the recording of this webinar for profit-making purposes, so we ask that you do not record the presentation. We are recording the event and it will be posted to the WPS GHA website on the Encore Presentations webpage, and it'll also be posted to our YouTube channel. Let's take a look at what I'm going to cover today. First, I'll give an overview of the FISS system, which will include the different ways the the system can be accessed. I'll discuss claim submission and the different paths claims may take after being accepted. I also want to talk about reason codes and status locations. This can really give you a better understanding of what is happening to your claim and what action needs to be taken, if any. Medicare has a lot of acronyms, and when you start talking about the system, it seems like there's a lot more and it could get overwhelming. I have provided a list of acronyms here so that if I mention a term that you're not familiar with, you will have something to reference. And here are some more acronyms that will be talked about today. So I'll start with a little background information and system access. FISS stands for Fiscal Intermediary Standard System. You may also hear it called the Fiscal Intermediary Shared System. It is the claims processing system for Medicare Part A claims. And I just want to clarify what I mean by Medicare Part A claims. I'm referring to services that are billed by a facility. So these claims can include both inpatient and outpatient services, and they're submitted by facilities such as hospitals, skilled nursing facilities, and rural health clinics, just to name a few. They do not contain professional services. Those services are billed on a CMS 1500 or an 837P, and they are processed by the multi-carrier system or MCS. Providers are able to access FISS via direct data entry or DDE. Access to DDE is something that would need to be requested from the MAC, and I will go into a little more detail about that process in a few minutes. Once DDE access is received, users can perform a variety of actions. Claims can be manually keyed into the system. If a claim has an error which requires provider action, the claim will be sent to a location that will allow corrections to be made. Adjustments and cancels can be made on certain claims. Access will also allow users to make inquiries. There are actually 16 pages of beneficiary eligibility information that can be accessed. You can do a claim inquiry to see if there is a payment process. One of the pieces of information the claim inquiry inquiry will give you is the status location. And we're going to talk about this a little later, but that piece of data can also tell you a lot about what is happening with your claim. Other details that can be obtained is if there's an additional development request that needs to be handled. And the last bullet on here is various inquiries. So there are options on the DDE inquiry menu that will allow you to look up descriptions of revenue codes, HCPCS codes, and diagnosis codes. Um, if there is an error on the claim, it'll be assigned a FISS reason code. And if you don't know what that FISS reason code is for, there's an inquiry screen that will give you an explanation of the edit. And if provider action is needed, it will tell you how to correct your claim. There are a few options when it comes to how claims can be submitted. Most of the claims that WPS receives are through electronic submission, and claims are submitted via electronic data interchange using an 837I file. This does require users to register for a trading partner account through our WPS EDI department. Next, we have DDE. This also requires the user to request access, but this time it goes through our claims department. And there are a couple of team members who are dedicated to working on DDE access and issues. So once access is granted, claims can be manually keyed into FISS. And the screens follow the CMS 1450 form, also called the UBO4 form. The last option we have is paper claim submission. I'll talk about this more in a minute because there are only certain circumstances in which paper claims should be submitted. Paper claims can take a couple of different routes. They could be given to members of the claim department to be manually keyed, or they can go through optical character recognition or OCR, and this process scans paper claims and it converts them into electronic files, which are then uploaded into the system. If you are interested in submitting your Medicare claims electronically, there are a few steps that need to be taken. On the resource slide, I've included a link to our EDI department's webpage, which is Getting Started with Electronic Claim Filing. And the first step is for you to choose your filing option. So your facility can file their claims directly to Medicare, which will require a software program. Now, providers can write their own programs. They can use a software vendor's programs, or WPS does provide a software called PCA's Pro 32. And it can be downloaded from the EDI website, and you can receive notices when updates are needed, as well as instructions that'll walk you through the process. So you'd get notified that your PCA's Pro needs to be updated, and you just go out to the website and download the update. The other options are to use a clearinghouse or a billing service. Now, our EDI department does provide a list of all vendors, clearinghouses, and billing services that have been approved for electronic claim filing. And the site lists all of the contracts handled by WPS. So you'll want to be sure to choose the list for the WPS GHA Medicare. Next, you will need to set up a trading partner account in the WPS Community Manager. This is a self-service tool that will allow your facility to create and manage accounts. I won't go into a lot of detail here, but if that is something that you would like information on, it's all covered on our EDI website. And that link can be found under the quick links on the WPS GHA homepage. Next, we're going to talk about DDE access. And before you start the process of requesting access, you're going to want to make sure that your provider is set up to allow DDE submitter IDs to be issued. And to do this, you're going to want to contact a Medicare DDE analyst. I'm having Aline add a link in the chat, and this will take you to the DDE systems page, which lists a phone number and an email address as well as hours of operation. And they'll be able to tell you if your provider number is set up correctly so that you can continue the process. That way you don't start submitting forms just to find out that it can't be done. Once you've verified that you can continue with the process, a facility administrator will need to submit authorization. Now, this authorization would need to be on a company letterhead and should name the person who will be requesting a submitter ID. An example would be if a member of the board wrote a letter on company letterhead stating that they were requesting that Karen Curtis obtain a submitter ID. And this letter can then be scanned and emailed to our DDE analyst. After the email is sent, the requester will immediately want to submit the DDE submitter ID request form, and that is located on the WPS-GHA webpage. I've also included a link to the form on the resource slide. This form is going to establish an authorized signer, and that designated authorized signer is going to manage or be basically the gatekeeper of who has system access. The authorized signer will then submit the DDE electronic access request form for individual employees. This form can be found on the WPS-GHA webpage, and a link has been provided on the resource slide. The form will assign users a DDE ID, which will allow them to log into the FISS system. Now, for those of you that are new to this process, I know that's a lot of information to take in. So please know that our DDE staff is available to help you through the process. So you can call them and they will walk you through and help you fill out forms and all that. Earlier, I had said that the majority of our claims here at WPS are received via electronic submission. And in October of 2003, the Administrative Simplification Compliance Act required that all initial claims for Medicare reimbursement be submitted electronically. Now, this does not include adjustments or claims corrections that are submitted on previously submitted claims or appeals requests. Small providers were exempt from this rule. A small provider is defined as a provider of service with fewer than 25 full-time equivalent employees. There are other exceptions for claims that meet specific conditions, and some relate to Medicare secondary payer situations. So I've provided a link to the chapter in case someone would like more information on those exceptions. Next, we'll move on to talking about claim submission and what can happen once those claims are accepted into FISS. I've created a flow chart so that you can see the different ways a claim can get into FISS depending on the way the claim is submitted. So there is editing that occurs at each step, and there are different actions that can be taken depending on what the editing software finds. So I'm going to discuss these steps in more detail, but I just wanted to give you a picture of the overall process. Electronically filed claims will need to make it through the translator and the Common Edit module known as the CEM before being loaded into FISS. Paper claims that are scanned and sent via OCR enter the process at the CEM, and paper claims can also be keyed directly into FISS by internal claims staff. DDE allows providers to manually key claims directly into FISS. This flow chart also shows the action that FISS may take on claims, which we will talk about shortly. So you can see that once they get into FISS, they could suspend, return to provider. There could be an additional development request. They could suspend to ECPS. Claims could be rejected or denied, or they could pass all the edits and go through. For claims submitted electronically, the translator provides the first round of editing. And the first notification that could be received is called a TA1. Now, this occurs when the file's been rejected. And in my experience, this happens when there's some type of formatting error. The second notification generated by the translator is a 999. And this is a file level notification that will let you know if the file was rejected, accepted, or accepted with errors. So if it's rejected, then corrections have to be made and the file can then be resubmitted. If it's accepted with errors, that means that the claim does have errors, but it's going to be allowed to continue processing. The second round of editing occurs in the CEM, or the Common Edit module. The 837I files that have processed through the translator and were either accepted or accepted with errors will then move into the CEM. Now, this is also the place where OCR files get loaded. Like the translator, the CEM will also send a notification, but this time it is a claim level notification. So the 277CA will generate and will let you know if each individual claim within the file was rejected or accepted. Now, those claims that are accepted will be assigned a document control number or a DCN. And you might also hear this being referred to as a claim number. So that claim number is something that could be used down the road to check status and things like that once it gets loaded into FISS. FISS serves as the third round of editing for claims. Providers can use the DDE system to manually key claims into FISS. Some claims may also be keyed by internal staff if paper claims meeting the criteria are received. There are a lot of actions that can happen to a claim once it's loaded into FISS. Some claims may suspend, and this usually occurs when the claim has an edit or a reason code, and it requires somebody in our office to look at the information on the claim and determine how that claim should continue processing. Sometimes that may require staff to reject, override, or RTP a claim. RTP stands for Return to Provider. This means that there's an error on the claim that cannot be corrected by internal staff. And this requires the staff at the facility to look at the claim and determine what needs to be done. There could be a keying error, for example. If a date's entered incorrectly, it could cause the claim to hit a reason code. And since internal staff can't decide if that date's correct or if it should be a different date, then that claim would have to be returned back to the biller, and then they would have to make that determination. Another acronym, ADR, this stands for Additional Development Request. An ADR is generated with our office when our office needs documentation to support the services billed. You may receive an ADR from our medical review department because they need to determine medical necessity. And ADRs are also generated when there's overlapping claims. So if a hospital and a skilled nursing facility are both saying that the beneficiary was an inpatient and they're at their facility on the same day, then our office is going to request documentation so that we can find out where the patient was and who should be able to bill for that particular day. Claims may also suspend to ECPS. Now, ECPS it's kind of a computer program where the computer will work the claim without manual intervention, and that way the claim can continue processing. This kind of allows the claims analyst to concentrate on workload that needs more of analytical thinking. Claims may be rejected due to system edits, or they could be denied for medical edits. Lastly, the claim may sail through the system with no edits and just continue on the path to being finalized. If your claim does happen to be worked by ECPS, the system could perform the same actions as FISS. So ECPS may work the edit, and which would cause the claim to continue on its path to finalization. Claims may be suspended. Maybe ECPS wasn't able to work the edit, or maybe after correcting the claim, it hit another edit, and that may have to be worked by internal staff. So for example, if the claim is editing as a duplicate and ECPS overrode the claim to allow it to continue processing, but then it hit an MSP edit, well then it would suspend, because somebody in the MSP department would need to look at that. ECPS can also RTP claims. It can reject and deny claims, or it can also send it to a location to generate an ADR. We'll move along, and we're going to start talking about FISS reason codes. FISS reason codes are 5-digit alphanumeric codes that can let you know what is going on with the claim. Reason codes are broken down into different ranges, and the edit can tell you where the claim is in the process. I'll talk a little bit more about ranges in just a minute. Reason codes will tell you if you have an error on your claim, if that claim is editing for review, and if the claim has been finalized. There may be times when you will see multiple reason codes assigned to a claim. And in order for the claim to continue processing, each reason code has to be addressed. So sometimes that can happen, like if there's multiple I can't think of the word I'm looking for, fields, that's multiple fields on the claim where maybe dates are incorrect, or maybe there's an invalid code being used in a certain field, then you could have 3 or 4 reason codes that go along the bottom of the claim. And one could be like the occurrence code date's wrong, and one could be you can't use this modifier with this revenue code. So you'd have to fix every single one of those reason codes in order for the claim to continue along the process. Now, this is not an all-inclusive list of the reason code ranges, but it was some of the ranges that I thought you would see most often. Reason codes that begin with a 1 are consistency edits, and they're usually related to the data on the UB04 fields. So you might get a reason code that begins with a 1 if the data wasn't correctly formatted. For example, if a field on the claim is formatted for only numeric data, but a letter gets entered, this would cause the claim to edit with a reason code beginning with the number 1. Another example would be if the admission type was not valid for the type of bill, or if it was left off the claim. Codes that begin with a 3 are FISS reason codes. These are hard-coded and are loaded when MACs receive a FISS release. Some common reason codes that you will see in this range include duplicate edits, timely filing, and reason codes that are associated with Medicare secondary payer. Codes in the 5,000 range are associated with medical review. So these can be medically unlikely edits. They could be related to a national or a local coverage determination. Just a couple examples. Reason codes that are site specific are created by the MAC. Those begin with a 7. So this usually occurs when our office would get directive from CMS stating that an edit must be created for a specific billing scenario. For example, CMS could give us directive that if a specific service was billed with more than one unit, then we'll need to edit the claim and review it to see if maybe the services should be denied. Reason codes that begin with a W are edits associated with the Medicare code editor and the outpatient code editor. Both programs detect and report errors in the coding of claims. The Medicare code editor looks a lot at diagnosis and procedure codes, among other things, on inpatient claims. You could see a claim editing because a diagnosis code that was billed on the claim is for a newborn, but the beneficiary is 70 years old. So that's going to kick out. Now, the outpatient code editor, uh, as stated in the name, is a software program that screens outpatient claims for both OPPS and non-OPPS providers. And when I talk about OPPS, I'm referring to the Outpatient Prospective Payment System. The OCE will also check for invalid entries related to diagnosis and procedure codes, along with modifiers and coding pairs related to the National Correct Coding Initiative. So in those cases, you may get an edit, like if two HCPC codes are billed on a claim, and maybe there's a rule that in order for those two services to be performed on the same day, then there must be a modifier. And if that modifier is not in the claim, then the OC is going to kick that claim out with an edit. The last bullet is for other alpha reason codes. Now, these are common working file or CWF edits, and I always considered common working file to be the kind of the beneficiary's master record, because claims from all of the different Medicare contractors are all posted to common working file. So it literally keeps track of everything. Although common working file edits could begin with any letter of the alphabet except for W, the most common letters that you are going to see are the letter C, E, and U. Common working file edits will let you know if days have been applied correctly to inpatient claims. It will edit claims if they overlap with a hospice election or with a Medicare Advantage plan. And it will also make you aware of overlaps with other hospitals or skilled nursing facilities. The last topic that I would like to cover today is status locations. So knowing a claim status location and what that means can give you some idea of what is happening with your claims. On this slide, I've broken down the different values for the status and locations. Most of these are self-explanatory when it comes to status. One that you might not see very often is the I. This happens when an internal staff member has inactivated a claim. And when that happens, you will not be able to make any changes to the claim, and it eventually is just going to drop off the system. So you'll know it won't even show like it's ever been billed. The first letter of the location can be an M for manual, an O for offline, or a B for batch. The first two letters, or the first two numbers, are the driver's location, and the last two are the location. Now, the main thing that I always remembered for the last two digits was that if it was a 9-6, it was on its way to where it was going to be headed, and if it was a 9.7, it made it there. So this example up here on the top of the slide is showing a status location of PB 9996. So it is on its way to being finalized, but it hasn't been finalized yet. Once it is actually finalized, it would move to PB 9997. I wanted to provide you with a list of some common status locations. PB 9000 means that the claim is processing through the drivers. So if you've ever corrected an error on the claim and then stored it, it'll move to SB 9000 as long as no other edits exist. And then it just starts moving back through the drivers again. TB 9997 is a return to provider location. This means that a correction needs to be made, but it is not something that can be handled by internal staff. So we are sending it back to you to make the correction. I had talked earlier about the location 996 means it's on its way but hasn't made it. So if you see a claim that is in TB 9996, that means it is coming back to you to make a correction, but you're not going to be able to access that claim and make changes until it's actually in TB 9997. The RB 9997 means that the claim has been rejected, while DB 9997 means that the claim has been denied. PB 9996 means that the claim is on the payment floor. Now, the payment floor is a waiting period in which a contractor is not allowed to pay, issue, mail, or finalize the initial determination on a claim. So for electronic claims, the waiting period is 14 days. And for paper claims that are not that are eligible for will not be eligible for payment until 29 days. So after that waiting period, then the claim's going to move to PB 9997, and that's going to be considered finalized. So that's when it's going to populate to a remittance advice, and you'll see the final processing. I wanted to talk about some common suspense locations. Prior to taking this position on the outreach and education team, I was a member of the systems testing team, and I would get referrals from providers who would call in and wonder why their claim was sitting in a certain location. So I wanted to talk about a few of these so that if you see a claim sitting in one of these locations, you'll have a better understanding of what's actually happening to it. The main thing to remember is that claims in these suspense locations are usually part of workload for internal staff. The first one, we have the edit U5601. That's a common working file edit when there is an overlap between facilities. So both facilities are claiming the patient was an inpatient on the same day. So our staff is going to request medical records. They'll review that documentation so that they can find out where the patient actually was. When that additional determination request is sent, claim staff is going to take that claim and they're going to move it to status location SM5601. That way it's kind of sitting there waiting for those records, and then that way nobody goes in, they don't change anything, the claim doesn't process and deny for overlapping dates of service. It's just kind of a hold. The next one, any location that begins with a SM68 is part of the workload for the MSP department. So anything that you see in one of those locations is going to be worked by a member of that team. SM hold is something that is used during quarterly releases. FISS send system updates quarterly, and when those updates get installed and into production, claims are held in the SM hold location for up to 14 days. Now, the reason that this is done is because if things don't go smoothly with the installation, claims aren't processing incorrectly. So it's kind of a safety net. There's also times, if any of you are not new to Medicare, when the pricers get loaded that price like inpatient claims and things like that, sometimes those get pretty late in the game. And so we just hold those claims for 14 days because we don't want claims getting denied incorrectly or even paying incorrectly. And then after that 14 days, those will be automatically released. The next location on the list is ECPS locations. And the asterisk after the SMSPR can be either a letter or a number. Claims in these locations will be worked by the system. The SMSYST is a location that is used by claims and system staff. It is used to hold claims to determine if there is a possible system issue that maybe needs to be referred to FISS. The claim is moved to this hold to prevent it from processing any further, and so that changes are not made to the claim data. The last location I've listed is SMTE, and the asterisks at the end of that will be numbers. This location is used specifically by members of the systems team, and sometimes if a system problem is discovered and staff will have claims sit in one of these locations until that fix is received. And then once the fix is received and installed, then the claims will be released and allowed to process. This is basically just to prevent any incorrect processing that could lead to mass adjustments. The last group of locations that I wanted to talk about today is related to our medical review department. And if you find that one of your claims is in a status location of SB 6000, that means that an ADR is going to be sent the next day and that you will have 45 days to supply the requested documentation. Once that ADR is generated, the claim will move to SB 6001 and it will remain until documentation is received. Or if we don't receive documentation, then the claim will be denied for no medical records received. Once that documentation is sent in and we get it here in the office, then the claim is moved to SMR doc. And that means that WPS has received your documentation and that it's being reviewed. I have provided you with a list of resources that I hope you will find helpful. The first three are for those who would like to get signed up for electronic claim submission and for DDE requests. I also have the DDE manual listed. There is the WPS YouTube DDE playlist. I know that a lot of providers now with the closing of the correction line, a lot of providers need help navigating through DDE. So we do have that playlist available. And the last one I put on here is the reason code lookup tool. That's on the WPS GHA website. And that will, if your claim hits a reason code and you don't know what it means, you can use that tool and put in the reason code and it will give you some information on that. Well, that brings me to the end of my presentation. So I am going to turn it over to Aline and ask if any questions have come through in the chat.
Yes, thank you, Karen, for that great information. We did get a question, and I was trying to pay attention to what you were talking about when the question came in. So this is from Deborah, and I believe it's when you were talking about the path of the claim and when the claim gets to the CEM. And Deborah, you can put something additional in chat if I've misunderstood what you're asking. She says, if the claim is returned to provider, does the claim receive a DCN? And then it would have to be rebilled as a corrected claim.
The claim would receive a DCN, so anything that goes through the CEM gets assigned a DCN, and then it gets loaded into FISS. Then once in FISS, that's when it could be like RTP'd, or it could be suspended, or it could just go through and pay. So you wouldn't, just because a claim is RTP'd, there wouldn't have to be a resubmission. If you have DDE access, then once that claim gets in that location I talked about with the TB 9997, you would have access to go in and make updates and then store the claim, and it will continue processing. So hopefully that answered your question. If
Yeah,
it didn't,
and that's what I
please
was
let us know.
thinking too. Yeah. Oh, and she says, yes, thank you. If anybody has any questions, please put them in chat, because that's the only one I'm seeing so far.
That brings us to the end of today's presentation. And before you go, I would like to tell you about an event occurring in August. CMS and Noridian Healthcare Solutions will be hosting a National Provider Enrollment Conference to educate providers and suppliers on multiple aspects of provider enrollment. The conference will be held August 28th and 29th in San Diego, California, and it is free to attend. Elaine will be adding a link to the chat, and this will allow you to see the schedule and to register if you're interested. On behalf of Provider Outreach and Education, I want to thank you for joining us today. We look forward to your survey comments and hope to have you join us for future events. You may now disconnect.